I'll talk a little bit about fragility fractures, which we all know about the treatment of, but the follow through is a critical problem that I think a lot of us have neglected. Academy of Orthopedic Surgery decided they were going to start an Own the Bone decade and that we were going to make inroads in treating these patients and take responsibility for it. But I think I'll show you some data that shows that didn't happen. So we know about low energy injuries that generally occur from a standing level, and we see typically the distal radius, spine, vertebral body, hip fractures, proximal humerus, and not to neglect the pelvic fractures. There are many insufficiency fractures that come in. We talk about bone mineral density, and terms that are often used are T-scores and Z-scores. A T-score is a bone mineral density compared to a normal individual at peak health. And a Z-score is a bone mineral density match for age and sex, and it's usually used for premenopausal women and men under 50. It's not used very commonly. The World Health Organization defines a normal bone density as greater than -1. And osteoporosis, if you'll see here, is -2.5. And when you order a bone mineral density test or DEXA scan, you're going to get these numbers. What is more interesting, though, is to look at the impact of who is being affected by this. And I think that most of us understand that postmenopausal women are at risk of osteoporosis, but we forget to understand that men are as well, and that fragility fractures are a significant source of pain and disability. And most of us understand the mortality of hip fractures and why it's important to treat these patients beyond the operating room. Once a patient sustains a vertebral body fracture, there's a 200% risk of sustaining any other insufficiency fracture and a 300% risk of a hip fracture. And that was published in 2015 by Miller and JBJS. The economic costs are staggering, $25 billion a year. And only 40% of people ever regain their pre-fracture independence. So we use the DEXA scan to diagnose these patients, but one could argue that if a patient falls down and breaks their hip and it has a typical osteoporosis insufficiency look or a sacral fracture, those patients have osteoporosis. It's like compartment syndrome. How do you diagnose it? Do you have to measure the compartment pressure in everybody, or do you just know because of the diagnosis? We look at a FRAX score as a composite of other factors in addition to the DEXA results and the bone mineral density tests. The FRAX was developed in the UK and Sheffield in 2008, and it gives us a probability of major osteoporotic fractures in the next 10 years. I don't know if you've ever looked at this calculation tool, but it's interesting. If you go to the UK site, the Sheffield FRAX site, you'll see a form, and you can find different populations to query. I just picked up US Caucasian here, but you can see that there's US other racial backgrounds that you can test. And it looks at age, sex, weight, previous fracture risk in a parent, smoking, glucocorticoids, rheumatoid arthritis, secondary osteoporosis, and alcohol. And then the actual bone mineral density is put in here, and then you hit calculate, and you come up with a number. So here's an example. I just arbitrarily picked a 60-year-old woman with a 56.7 kilogram weight, a height of 162, previous fracture of the wrist, parent with a fracture, current smoker, no glucocorticoids or rheumatoid, but drinks 3 drinks a day and has a bone density T-score -2.5. And that patient comes up with a major osteoporotic fracture risk of 39% and a 10% risk of a hip fracture. It's a useful tool. It doesn't mean everything, but it's a baseline, and you can use it to measure your patient's progress if you put them on treatment or somebody else does. The other things you need to look at are secondary osteoporosis. So if you were to contact or consult your endocrinologist, they may ask you, well, did you do a PTH or a TSH? Did you review their medications? Do they have sprue or celiac disease? Are they an autoimmune patient? And do they have excessive alcohol intake? We can take this history and probably run a few tests ourselves to get some background so that when we do contact the endocrinologist or the primary care doctor who's going to take this patient on, we have some information for them. So we know that steroids decrease osteoblast activity, but there are other drugs. Tamoxifen is used for breast cancer that has a detrimental effect on bone, and anti-epileptics, as you know, decrease GI absorption of calcium. So that's a medication list. So now, once we know the patient is osteoporotic, they've got a fracture, we've done a DEXA scan, we calculated the fracts, now what do you do? Well, the most important thing is to remember that these patients are asymptomatic. And the relevance here is that we do a lot of orthopedic surgery, elective orthopedic surgery with joint replacements and spine, that we should be looking at bone mineral density optimization in those patients, just like we look at glucose optimization and smoking cessation and weight reduction. And it's very relevant. And I think I'll show you in some slides why it's important to know that. Unfortunately, we're very negligent group of surgeons in this country. Our recognition is woefully low. Very few people actually get treatment. And if you look at some of the data, you'll see that the disease is poorly recognized. In this study by Balasubramanian in 2014, in the decade between 2001 and 2009, there was actually a decreasing treatment rate. Only 42,000 men had, of the 42,000 men in that study, only 10% had DEXA scans, and only 9 were ever treated, 9% were treated. So we fail to recognize these patients all the time. A Danish study published this past year looking at the gap between patients who were diagnosed with fractures and those who were treated, found that they could reduce the gap from 85% missed to 79% missed. And that's arguably still an incredibly low number of people that are treated for this condition. And as you can imagine, we're not a third world country. We think of ourselves as being pretty smart, but this is the University of Virginia. And this was published this year in JBJS. Of 950 pelvic insufficiency fractures looked at 2 years later. After 2 years, 90%, 96% never had a DEXA scan. 92% were never administered treatment, and 41% had additional fractures. Wow, if we were doing that with cancer or heart disease, we wouldn't be thought very well of them. So if you look at Own the Bone programs, which exists, you can increase the treatment rate substantially. So a fracture liaison service, or FLS program, uses a physician, leader, and nurse practitioners and staff to identify these patients, set up the tests, look for secondary osteoporosis, establish insurance eligibility for these patients, and initiate care. And this program was successful in enrolling 73% of the patients that were brought in, and only 12% initiate care. Not everybody's going to be treated, but this number is so much better. What was interesting is that you would think that women as a risk factor would be a target population, but it turns out that sedentary lifestyle and hip fractures were the risk factors that were most likely to be picked up by this Own the Bone group. So we want to capture patients who sustain a fragility fracture. We want to prevent secondary fractures, and we want to institute treatments. That's our goal. The non-pharmacologic measures, as you might think of, are fall prevention, reduce alcohol, coffee, and smoking, exercise, dietary improvements. Most of the time, though, we're going to start working with some type of medication. This is a class that we're all pretty familiar with. These drugs have been around for decades. The bisphosphonates, they uncouple bone formation and remodeling, and they have their problems. There are we'll talk about that in just a minute. Raloxifene is not used very often. Calcitonin is not a very good drug, but it is used for vertebral fractures. Parathyroid hormone, I think, is really an interesting medication and probably should be thought of as actually a treatment modality for some of the pelvic insufficiency fractures. And denosumab, which is a rankle antibody, blocks the conversion of osteoblasts to osteoclasts and that's been useful as a treatment. Prolia is used by the endocrinologists a lot, and Ramosozumab, if I got that right, is a sclerostin antibody, and sclerostin inhibits osteoblast and bone formation. So if you block sclerostin, you may increase the bone formation. So those are some of the drugs that are used. And but why should we be concerned about osteoporosis in our elective practice? This was the most eye-opening thing for me to know. This was a study that was just published in 2021 rather, and these were post-op hip replacement patients, 268 treated with DEXA scans. And of those 268, 18% had T-scores less than minus 2.5. 41 had scores that were in the osteopenia range. But 73% of those people who had a T-score minus 2.5 were undiagnosed previously. And we're putting in cementless prostheses in these people. I think we have to be thinking about it, especially now if people are starting to use, surgeons are starting to use cementless knees. I think we need to look at this. And maybe all of our patients should be treated or evaluated preoperatively with DEXA scans. So we know about the higher rate of cementless total hip failure due to fracture in patients over 75. Cemented stems tend to do better compared to cementless. There's a lot of literature now that supports that. And if you look at, I think this was a bundled program. Yeah. Edelstein was published this in 2020 that patients who were in a bundled care program for hip replacement were more likely to be cemented if they were elderly females because of the risk of periprosthetic fracture subsidence, poor osseointegration. So I would suggest that we should be thinking about using DEXA scans preoperatively in a lot of our patients, especially if we're considering using cementless prostheses for hips and knees. And this has been shown, the denosumab has been shown to reduce the risk of stem subsidence and femoral bone loss. Another thing to think about is vitamin D. Most of us don't appreciate that a lot of our population in the Northwest is vitamin D deficient. And I thought this quote from Robert Healy was kind of cute. Vitamin D makes every cell the best it can be. Well, what is vitamin D and why? We know that vitamin D is necessary for GI absorption of calcium, but it's also important for normal macrophage activity and promoting an inflammatory response. And it may risk to reduce arthroplasty patients are insufficient in vitamin D. I've been telling my patients for years to take vitamin D preoperatively. At levels below 30, we see things like stress fractures, fragility fractures, post-op infections, poor spine fusion healing, delayed fracture healing, and non-union. This was a really cool study. It was a total joint infection model using mice. And these mice were sustained on a vitamin D depletion diet. And they were then implanted with a metal rod, and then their joints were injected with Staph aureus. The cohort of these rats was given one dose of vitamin D, and the bacterial burden dropped substantially. This was remarkable. Just one dose of vitamin D substantially reduced the bacterial burden in these this total joint infection model. So again, maybe we should be thinking of vitamin D as a preventative medication for our patients. So I suggest 1,000 to 2,000 international units a day to my patients, and you might want to consider that. I don't know if we want, Jens, I'm at 15 minutes. Do you want me to stop at that point?
Sure, that'd be nice. I have two quick questions, and then we want to go to our featured final speaker, Alan. So I heard that DEXA scans are not transportable, meaning the accuracy of one unit to the next has an error rate of about 10 to 20%. Is that correct or wrong?
I don't know. I can't answer that question, but I can say that if you're doing sequential DEXA scans, you'll probably get a rough idea. I think the difference between a 10 and 12% fracture risk is moot. I don't think that anybody's going to be concerned about that, a FRAX calculation, but I think that if you're seeing some upward movement with your T-score, that you're getting the effect you want.
So big request. Are you able to share elements of your recommended lab tests and basic synopsis to our membership so we can spread that around? The Greenwald's recipe for getting to the basics of back to bone.
You can do a preoperative vitamin D, and hopefully it's over 30. I don't know what the units would be, nanoliters per ml. You want a vitamin D that's in the normal range. That'd be one thing. I was having trouble getting insurance coverage for the vitamin D preoperative evaluation, so I just started putting people on vitamin D just arbitrarily.
Super.
And I'm starting to think about ordering a DEXA scan on everyone I'm going to use a cementless prosthesis.